Thank you again coming back this year to talk at our symposium. He is a board-certified ENT from University of Michigan. Not only is he known for his clinical practices, but also as a researcher. He has been in practice for more than 40 years now, and his research on the role of glutathione in many diseases has led to the formulation of Redysorb glutathione, which we all are familiar about. His publication includes articles on the neuroprotective qualities of liposomal glutathione in the detection of mycotoxins in mold-related patients, deficient glutathione in mycotoxin-related illnesses, and many more. The title of his talk today will make you a little bit more hungry today. It's called Changes in the Production of Glutathione, SNPs, Chips and Tips, and Their Management. Dr. Tim Guilford.
Thanks. How long do you want me to talk?
You have an hour, 45 to
50? 40? Okay. Well, it's a pleasure to be here. Over the last couple of years, I've had postgraduate education in medicine, so it's a pleasure to be anywhere on this planet. So what I'm going to talk about, I'm going to see if I can get this to set up. I was going to do some timing, but title is SNPs, Chips, and Dips. We're all familiar with SNPs, single nucleotide polymorphisms. Here's the, we'll just advance it. Which one? There we go. And I'm going to start out talking about chips, changes in the production of glutathione. Well, this happens with what we call hormesis. We're all familiar to the concept of exposure to a mild stress improving your ability to withstand it. This is particularly true in exposure to oxidative stress. And so it's been shown that this is beneficial to organisms, and people argue that you need some oxidative stress, which results in the upregulation of glutathione. And it turns out exercise increases glutathione, and the reactive oxygen species are needed to stimulate some normal cell functions. With marathon training, you increase your glutathione as you progress in your training, and at 20 weeks it becomes increased definitely, your total glutathione. After 40 weeks, you get increased glutathione and an increase in glutathione reductase. That's an enzyme that the body uses to recycle glutathione. That's where you go from the GSH to GSSG. That's the oxidized form of glutathione. You need to be in the reduced state, GSH, in order for glutathione to be active and do its function. And the other thing that will go up after prolonged training is the glutathione S transferases. Many people confuse the testing for glutathione S transferase as being an indicator of the production of glutathione. They're two separate entities. The transferase is an enzyme. All enzymes work like matchmakers. The matchmaker introduces in this case, glutathione to a toxin, and that will result in improved removal, binding and removal of the material. So that's what the transferases do, and there's a whole library of transferases. But the key here is that they all need glutathione to function, and most people don't think about that. If they see a SNP in GST, yes, they are deficient in their ability to use glutathione, but increasing the glutathione may actually take care of that because it will increase the likelihood glutathione will meet whatever it was the transferase was designed to introduce them to. In regard to POPs, persistent organic pollutants, they will deplete glutathione over time. Some people say that initial exposure to POPs actually increases glutathione production. The problem is persistent nature to these, persistent exposure to these materials may result in a decrease in endocrine function and other systems, so that it's a race between how much glutathione can you make and get rid of the persistent organic pollutants that you're exposed to. And even low doses of exposure can accumulate over time so that older people have an increased accumulation of POPs. Coincidentally, as you get older, most people decrease their glutathione production. So it's been proposed that for public health purposes, that increasing exercise will help remove these kinds of exposures. But once again, you're running kind of a race between developing the materials for removal and the effect of the material. And this has been talked about in the endocrine literature, and a number of conditions, not only related to the endocrine system, including diabetes, are now associated with exposure to POPs. So it looks like these toxins create a cumulative risk for certain populations. And they talk about the CRAs in regard to vulnerable communities or populations. I would propose there's a group of people in whom these toxins are more of a risk, and that's the people who have either early in their life or later in life developed a deficiency of glutathione. I'll show you some studies to support this concept. And so single nucleotide polymorphisms become introduced at this point because they will affect the production of glutathione depending on where they hit. Many SNPs cause problems, not all do, and there's a wide range of SNPs that are going to be introduced in the future, although we're familiar with that are associated with the methionine cycle. That's been available probably for awareness of this impact of SNPs in this cycle have been around for at least 15 years. So most of us are now familiar with the MTHFR inefficiencies in terms of methylating B12 to make methionine, and the cycle in which homocysteine is produced, which will produce cysteine. I think most of us thought that by the time you got to cysteine, that was a pretty straight shot to the formation of glutathione. It turns out that there's some enzymes that occur in this pathway that are also vulnerable to decreased production. So these enzymes are glutamine cysteine ligase that ties the enzyme together with glutamine and cysteine for the first step in the production of glutathione. Then there's an enzyme called glutathione synthase that takes glycine and adds it, so you ended up with glutathione. I think we need to be aware of the fact that there's some problems that can occur in the production of GCL. That includes the formation of the catalytic unit, GCLC, and GCLM, the modifier unit. The GCLC defect will result in a significant reduction in the production of glutathione when that is present. This can occur with a SNP or actually a loss of expression. GCLM, you get decreased glutathione, but usually only about 40%. Now it turns out that GCLM, and I incorrectly put in here that it's a SNP, it appears like that. I haven't found confirmation. But some children with autism have been shown that in their brains, they do not express the GCLM modifier unit of glutathione. And that's one reason why these kids end up with low glutathione as a marker of their condition. There's some other conditions that have these inefficiencies. One is HIV disease, in which GCLC is not expressed, meaning they have the genes, but they're not forming that catalytic unit, and therefore they don't make glutathione. Type 2 diabetes has also been shown to not express the GCLC. So I found a study in which they were giving plain glutathione to people with liver disease, the non-alcoholic steatohepatitis, and the plain glutathione worked fine in the people who were pre-diabetic. But in the people who were diabetic, they quit using that administered plain glutathione. I'll come back and show you why that happens in just a minute. I want to mention the fact that even autoimmune disease like systemic lupus erythematosus has been shown to not express the GCL enzyme itself, so they're not making glutathione adequately. I found this one article, but it's rarely referenced beyond that. So a lot of this information is just not reproduced in the literature, but there are definite articles that I've referenced here. So these SNPs occur in a number of conditions. In myocardial infarction, back in 2002, a study showed that GCLM was not present completely because of a SNP. GCLC SNP has been shown in chronic lung disease. And in people with pulmonary tuberculosis, they found over 1/3 of them had a SNP in the GCLC. Endothelial dysfunction has been demonstrated to have a SNP, and GCLC was then demonstrated along with GCLM in a 2017 article that confirmed this 2002 article. In people with ischemic heart disease, they can be affected by SNPs in these areas, which would lead to decreased production of glutathione. So in talking about these SNPs and in the decreased expression, are we talking about a susceptible group? Usually with toxins, we think about them affecting specific groups like children or people who work in a certain environment. But I think there's actually a bigger group that's kind of hidden within our midst, and I think these are a lot of the patients that we deal with. I'm not sure that replacing glutathione will necessarily restore health, because not only have you let the cows out of the barn when you don't have enough glutathione, but you've also admitted some other characters. And this can include mycotoxins, that can include metals, and some other toxins that lead to poor health. And I'll mention that a little further along. So there we get exposure to these persistent pollutants will change the production of glutathione, and that may show up as diabetes or cardiovascular disease. And hopefully SNP panels will be introduced in the future that are able to identify this group of people. Right now, portions of that are being examined in the GSTs, but the SNPs for the glutathione itself are not commercially available. I was hoping that would be available by the time of this talk, but perhaps they will be in the future. Now, if you don't believe these are critical, let's look at cystic fibrosis, the genetic problem where they don't transfer glutathione from the blood into the lung. So they have problems with their lung function. But it turns out that they may have cystic fibrosis transfer receptor protein gene problems, but there are actually phenotypic differences that occur that are related to both the GST SNPs and GCLC SNPs. And the severity of cystic fibrosis can actually be determined by the presence of these secondary gene problems. So they not only have the primary genetic problem of not getting glutathione in, but if they don't manufacture glutathione adequately or use it properly, they're going to have a bigger problem. So what I'm beginning to hypothesize is that the production of glutathione may vary in different people. It's not always the same. This diagram sort of illustrates the fact that they may not have full expression of the enzymes, and if they don't, they're not going to produce adequate glutathione. Of course, there are people, as we all know, family members who can be exposed to a mold-laden house and not have any problem at all. I would suspect these people are making a lot of glutathione in addition to having improvement in their T-cell function. And I'll show you a relationship in their immune function in just a minute. So let's talk about lunch for a minute and talk about the Maillard reaction. That occurs when you heat, especially carbohydrates and protein. You create browning, and that actually adds to the flavor of our foods. You find this in seared steaks and a variety of cooked and toasted materials. The high temperature produces a material called acrylamide, which is an oxidizing chemical itself, the production of heating food. And if you don't have adequate detoxification pathways, you can develop risk for problems related to this material. The potato chip has acrylamide, and in this study they took healthy people and they gave them 3 bags of single-serving potato chips a day for 28 days. And this created a situation where they got alterations in their acrylamide hemoglobin combinations as well as some of their immune functions. We'll go over that in a minute. And this occurred after ingestion of plain old potato chips. Well, what happened? You've got the acrylamide hooked to hemoglobin. They also showed they had an increase in oxidized LDL protein. It went up significantly. Here's your acrylamide showing its increase. IL-6, a cytokine that's associated with oxidation stress, went up. CRP went up, and so did GGT. Gamma-glutamyl transpeptidase. Well, we've heard about this, but we don't really think about it very often. It's a very simple biochemical that shows up on our routine testing if you ask for it. And what it is a marker that will show up on the outside of cells that's actually an enzyme that will convert whole glutathione into the amino acids that can then be absorbed and put back into the cell. And this works really well in most cases, unless you have a problem in the enzymes that are needed to reconstruct the glutathione. Well, where does this occur? We'll come to that. Potato chip, they showed these potato chip exposures decrease the glutathione inside cells in addition to these secondary markers. So if you get a decrease in the production of glutathione, you'll end up with these kind of problems that we've talked about. And a follow-up study I found subsequently in 2017, they showed that eating fried potatoes just twice a week would increase the mortality by over a factor of 2 in people. So what this points out again is that some people can tolerate this material on a regular basis, but not everyone. So if you're prone to these kind of problems, it might be wise to limit your fried food intake because that may drag down the production of glutathione. So a study was done back in 2007 with liposomal glutathione in which they took it and they gave it to the ApoE knockout mouse. This mouse doesn't make ApoE and they accumulate excesses of cholesterol. And it turns out that coincidentally, whether that's a cause or an effect, they also don't make adequate glutathione. In these mice, in people, they were able to demonstrate before the animal study, they took copper ions and put them in their blood, and that created an increase in oxidation. This is lipid peroxides in the lower portion B here. When they gave small amounts of liposomal glutathione into the blood sample, it prevented the oxidation of LDL. So there's a clue there that glutathione plays a role in prevention of oxidation. They then went on and in the mouse model showed that HDL-associated or induced cholesterol efflux, which is a macrophage-mediated function. We're not taught about that, but when you think about it, your macrophages play a big role in recycling cholesterol, play a huge role. So adding liposomal glutathione increased that cholesterol efflux. It had the result of decreasing atherosclerosis in those mice by 30%. Now that's mice. So here's the model that's appeared to me to be occurring. You get accumulation of cholesterol that can become oxidized. Your macrophage has picked it up, but then they go under the artery lining to rest and to rejuvenate as they metabolize this material. And there may be several of them accumulating, and they're just sitting there like fat pigs after eating a big meal. They're trying to rejuvenate, if you will, metabolize these materials. So they'll pile up and they begin to narrow the artery. And then the artery can become inflamed because of the influx of other cells and inflammation associated with some of these cells that die. And you get a thinning and then a breach of the artery wall and a clot. And that will accumulate and cause ischemic heart disease. These are supposed to represent intact functional macrophages. So the study went on to show that both LDL and HDL contain another enzyme associated with glutathione called glutathione peroxidase. Now the peroxidase enzyme prevents or reduces the formation of peroxides as they occur in the lining of the cell wall, for example. You have cholesterol there, but if it becomes oxidized, you can get a chain reaction that can follow down these long chains of carbon and create oxidation. So you need not only the peroxidase enzyme, but adequate amounts of reduced glutathione. And that's one reason why in that study in which they added copper ions to the blood, they could prevent the formation of oxidized LDL by adding reduced glutathione to the mix. illustrates that again. And to summarize all this, in 2016, an article was published coming out of Emory University, so it was no small unknown school, which showed a novel biomarker of oxidation stress associated with coronary artery disease. And this biomarker measured oxidized cysteine over reduced glutathione. So it turns out the amount of reduced glutathione in the plasma is a significant factor in predicting the ultimate endpoint of coronary artery disease, death. In other words, as your glutathione goes down, your risk of death goes up. Okay? So back to the articles on SNPs and coronary artery disease. The 2002 article showed that this is occurring due to SNPs and GCLM, but actually SNPs and GCLC and GCLM are both shown to occur in the population with ischemic heart disease. Now, it's hard for me to imagine that people go through their entire life with these SNPs without problem, but apparently they do until you get an accumulation at some point. Your body can't keep up any longer. So let's talk about the dips, the decreases in glutathione production. So this occurs, when this occurs, such as you get with the expression of the loss of the catalytic unit of GCL, you get an increase in transforming growth factor beta, TGF beta. You also get an increase in IL-6, and you also get an increase in IL-10. Now, I've left out a bunch of other cytokines. I'll show you those in a minute. But this kind of differentiates what's called the Th2 type of immune response. People that have Th2 really implies that their cells are not as efficient in killing an incoming invader. And instead, what they're doing is their cells are producing antibodies as part of a fallback mechanism. This will slow an invader down. They hit this wall of antibodies that are being produced, and that's the IgGs and even the IgEs that you see in people with allergy. So mycotoxins, it turns out, and this is where that ties in with mycotoxins, are thought to come either from aerosol exposure such as water damaged building or contaminated foods. And the first mycotoxin testing in humans was related to people that had been exposed to water damaged buildings versus those who had no exposure. And so it shouldn't be a surprise to us to find that you can find these toxins produced from the organisms that inhabit the wallboard. Now, when it's dry, these organisms are not being formed, but when wallboard gets water damaged, water infiltrated, these organisms start to grow and they start making the common toxins that we're seeing in these studies. So once again, I would point out that these problems are occurring related to loss of expression of these catalytic units, forming the GCL that forms glutathione. And this is after the production of the methionine cycle. And this may explain why some people are slower to respond to the introduction of vitamins and nutrients that support the methylation cycle, because they've still got to go through this glutathione reconstruction pathway. Even if you give plain glutathione, it may not be working as efficiently because, it's got to be broken down and carried into the cell and then reconstructed. And it turns out that in N-acetylcysteine, when that's introduced, they did a study in cells. It turns out these cells were taken from people with HIV in whom the GCLC is not being expressed. The liposomal form of glutathione worked 1,000 times more efficiently than NAC, which may explain my preference for one over the other. Again, in cystic fibrosis, these SNPs in the formation of glutathione may have a significant effect in the overall health of someone with that genetic disease, which is not good anyway. And as far as infection is concerned, people with tuberculosis have been shown, over a third of them have a SNP in the formation in GCLC gene that is associated with pulmonary tuberculosis. So that's really fascinating. We've been involved with some work that shows the benefit of glutathione in cells that have been infected with TB. We'll come to that in a minute. Of note is recent studies have shown that both plasma and brain glutathione is deficient in people with Alzheimer's disease. Now that won't be a surprise, maybe. The plasma glutathione was actually shown to be reduced by 84% in people with Alzheimer's disease. And they had a corresponding increase with malondialdehyde and 4-HNE. These are two more markers. The major markers are the peroxides. They use malondialdehyde, 4-HNE as markers of oxidation stress. And depending on what's oxidized, they'll go up. And there's also 8-hydroxyguanidine that suggests lipid brain oxidation. Proton spectroscopy has shown a lower glutathione level in the brain of people with Alzheimer's disease, even before they become significantly affected. And the lower glutathione levels were associated with a higher level of amyloidosis. So when you think about this in the oxidation stress, it begins to make sense. Turns out there's a study that shows that brain tissue of people with Alzheimer's disease also do not express GCLC. Now, I wrote a study with Jeanette Hope, who's the past president of the Environmental Association, in which we showed that these mycotoxins will prevent the formation of GCLC. It was a review article that looked at published articles documenting that GCLC is not expressed in the presence of mycotoxin. And I think that begins to explain some of the mechanism that occurs with oxidation stress. This 2018 article goes on to show that people with low plasma glutathione, it's predictive of cognitive decline in people who are otherwise healthy. And so there's a number of people, we heard Don Dennis talking about the mold and mycotoxin in the nose perhaps being spread more directly to the brain, but it would be a very convenient way to logically explain exposure and nasal mycotoxin accumulation and brain degeneration related to those things. There's a lot of peripheral association, if you will. It turns out Bredesen has written a book and several articles that shows that there's several agents that need to be treated when treating Alzheimer's disease, and he considers it to be a treatable condition. He likes to use vitamins and nutrients to support that methionine cycle. Although he doesn't say it in the article, he's actually supporting the production of glutathione, but he does make it really clear that you need to remove mercury, and you ought to look for elevations of tissue growth factor beta. Well, TGF-beta is associated with a loss of production of glutathione. There's clear studies that show that when glutathione is low, your TGF-beta will go up, and conversely, when it's up, you'll lose the expression of the GCLC and those enzymes needed to make glutathione. So if you remove those characters that have become accumulated in the person, perhaps due to their low glutathione condition, you can begin to reverse Alzheimer's disease. And I would submit to them, I wrote to Bredesen and his co-researcher, Dr. Rao, R-A-O, and Bredesen didn't return the email, but his research associate did, and he said he agreed that you ought to support glutathione if you're going to try and treat people with Alzheimer's disease. I don't know if anybody has used this information in treatments at this point, but you can understand why you're doing it now. We can address that in the Q&A. Oh. So these other articles, this one by Ballatore lists all the conditions that he saw associated with low glutathione back in 1985. He was looking at the secretion of metal complexes. And then here's the article that Jeanette Hope and I wrote about mycotoxins. And here's a reference to the studies that show that TGF-beta will prevent the formation of glutathione. So here's a clinical study in which people started out with low glutathione. It was shown they were stuck in the immune mechanism called Th2. Now the Th1 is where your cells are armed and ready to take care of invaders. And they used TB in the study as an example of an infection that you could repel. But these folks with HIV were low in glutathione and had a Th2 predominance. So here's that illustration. When you get HIV, you get increases in IL-6 that accompanies a decrease in glutathione. Some people think oxidation stress itself will increase this and or the other way around. And then you get a increase in TGF-beta, IL-10, along with the IL-6, and you get a decrease of these cytokines that are associated with the loss of cellular killing. When you give these people liposomal glutathione, they're able to reverse that. Their cellular killing effect can go up, including the production of IL-12, IL-1B, and the other cytokines associated with Th2 function will diminish. And they found that this will improve the control of infection. Let me list these for you. It's easier. That's why I just focus on the ones that are associated with Th2. If they're elevated, I begin to think that these people are in a kind of a defensive posture where they're making antibodies instead of attacking whatever it is that has come into their body and chewing it up. That's what our macrophages normally do. So if nothing else, take away from this talk that macrophages play a big role in maintaining our health. It sounds obvious, but it turns out they're dependent on glutathione for their function. So what they did is they then took cells from these people. We had a placebo group. It was double-blind. And so they took their cells and introduced TB. And in the people with the placebo, they had rampant growth of TB inside their cells. In the people that had been taking liposomal glutathione, introducing TB, it barely grew at all. So it shows these cytokines are determining the cellular function. And that's maybe the second thing that you should take away. And then we talked about TGF-beta, which people talk about all the time in mold cases. Maybe you've seen these elevations, as suppressing the formation of GCLC. Dr. Brewer's talk on chronic fatigue syndrome, his paper mentioned the association of mycotoxins and chronic fatigue, as well as a list of additional conditions. And I think it's worth looking at for both of those situations, so you understand what mycotoxins can do. One of the things that has come up in talking about mycotoxins is the presence of non-thyroid illness syndrome. That's kind of a confusing definition of a problem in which the thyroid is not functioning properly. So you can have people who have an illness syndrome even if they have normal-looking thyroid disease. So it's very difficult to diagnose, or has been, until they started looking at the level of reverse T3. So that these people may not make adequate T3, and if they make an excess of reverse T3, it will block the function of the normal thyroid T3. As you remember, you need to go from T4 to T3 to get activity of thyroid. And they actually did a study in people who had just had a myocardial infarction, and they found they had an elevation of reverse T3. Well, that wouldn't surprise us, because we now know that heart disease and ischemic disease is associated with low glutathione. And they took NAC to help build glutathione, and it seemed to prevent this decrease in reverse T3. Another study has shown that increases in IL-6 will predispose to this non-thyroid illness syndrome. So what is happening here? You have three major enzymes that are used to produce thyroid. Deiodinase 1 and 2 produce the normal T3. And if you don't have glutathione, deiodinase 2 doesn't work, and that's the primary one that will produce normal T3. So this is deficient in people with oxidation stress, evidence of IL-6 elevation, and also in mold and mycotoxin exposures. I'll come to that. So it's all due to low glutathione. The deiodinase 3 enzyme continues to work, and that's the one that makes reverse T3. So you get a production of reverse T3 that in many people will show an imbalance, but not always. but you need to think about this. Well, an article from Finland by Sompi, S-O-M-P-P-I, and I would recommend that anybody dealing with mycotoxins take a look at this article because it clearly shows that oxidation stress from mycotoxins is associated with the production of reverse T3. And they found that the use of Cytomel in 7.5 to 15 milligrams 2 or 3 times a day could be very effective. But they had a caveat in there, and that's why I encourage you to read the article. At the start of the talk, I mentioned that we don't really know, are we getting mycotoxins from the air or from foods? And this article by Sompi looked at people who had been exposed to a water-damaged building that had been damaged for 20 years, and they show this huge range of illnesses, including some of the ones that Dr. Brewer talked about, but also cancers and a high degree of thyroid illness. So it begins to make sense that if you have mycotoxins and they're depleting glutathione, the oxidation stress reflected by increased IL-6 will decrease the function of dehydrogenase 2 and continue the function of the D3. You'll end up with an increased amount of reverse T3, and this will block thyroid function. So these people, they recommended using Cytomel. But when you read the article, you'll see that they were all on a gluten-free diet. Now, why they chose gluten-free diet? They said that it was a diet that was the simplest way they could recommend to people to avoid foods that might be contaminated with mold. Now, I recognize it's not perfect. I'm just telling you what they mentioned in the article, and I offer it to you for your consideration. So, in looking at health over time, I think we try and build a wall, either literally or figuratively, to protect us from all these conditions that we're exposed to. Now, this was obviously taken from the Game of Thrones books and movies. Here you have civilization on one side protecting itself from something on the other side. Well, what are we talking about in this discussion? We're talking about the conditions that may affect our lives. As we stand on this wall of information that those of us in this room have accumulated, we'll look off to our left, which is chronologic in this presentation, and you'll see that you weathered autism. It's not likely that you had that disease when you were young, but you know that such a high percentage of people are exposed to that's a risk for young people. Some forms of immune dysfunction. When you have low glutathione, I wrote a paper that shows that all the common forms of ear, nose, and throat disease are associated with low glutathione. I didn't make that point. I reviewed published papers documenting that all the ENT diseases are associated with low glutathione, either in the tissue or systemically. Oh, that's curious. Why don't we know more about that? I've tried to get heads of department interested in reading the paper, but so far I haven't been very successful, but I'm very proud of it, and I'd recommend it to any of you who want to know where can you use liposomal glutathione, or where would people need to have their glutathione supported? How about during both chronic rhinosinusitis, which coincidentally ties in with the mycotoxin discussion that Dr. Dennis gave us earlier, or even allergic rhinitis, they're low glutathione. It turns out these pollens, in the exterior of pollen, they have oxidases, an oxidase enzyme that is released when they hit the mucosa. When they hit the mucosa, it releases that oxidase, depletes glutathione, and then if you get enough hits, you can begin to develop a clinical problem. At the very least, you deplete your glutathione in that area, and the immune cells responding to that will lead to a Th2 predominance, which coincides with our allergy picture, the production of antibodies. Well, what else happens in life? Well, we've got the potential for diabetes. I just mentioned earlier that GCLC is not expressed in people with diabetes. This is a published article. Several articles show that glutathione is low in diabetes. It gets confusing to try and go into all the details, but every time you get a spike in glucose after a meal, for example, you get some inflammatory reaction that is associated with loss of glutathione. The other thing that happens when you eat a meal is you get a release of glutathione out of your liver, and it is accompanied by the production of nitric oxide from these cells and liver that combines with to become GSNO, and that actually helps improve the sensitivity to insulin. So if you have a repeated spikes in glucose from eating high sugar meals, you're going to put more and more stress on that glutathione system, and that may lead to a decrease in insulin responsiveness that will end up resulting in diabetes. You can see this all the time. I got in a Uber car one day, and the driver was a nice fellow, and he said, man, he said, I'm having trouble with my controlling my glucose. I said, oh, why is that? And he said, well, last night I ate a perfect meal. I ate salmon and some other low carbohydrate materials. He said, this morning my glucose is up. I don't understand. I said, what do you do for a living? Well, I drive. And it turns out there's studies that show in people who are diabetic, if they live near freeways, their glutathione levels are actually diminished. Their oxidation stress goes up. And you can look at all the reasons for that, whether it's erosion of the rubber and the metals that are released or the other oxidants that accompany the pollutants. So that would explain his dilemma with diabetes. And then we add the POPs in there that are associated with diabetes, and they are depleting glutathione and disrupting the endocrine system in general. Vascular disease, I've shown you several studies that document that low glutathione will contribute to this. And then further out in our life, we all have to contend with the fact that we are susceptible to Alzheimer's disease and other neurodegenerative diseases. So I think that what we're going to learn is that glutathione, SNPs in glutathione, and decreased production of glutathione related to materials that deplete GCLC. Now, HIV is the prototype for that, but almost every virus is associated with a depletion of glutathione, at least transiently. And I'm aware of some data that would show benefit from supporting glutathione in a variety of viral diseases, but unfortunately it's not published yet. But maybe we can talk about that next time. But the relationship between glutathione and macrophage function is really important, and I think it defends us in terms of maintaining our health. So when you sit across from a patient and you're looking at them and their chronic problems, restoring glutathione alone will not necessarily solve the problem, but as Bredesen has shown, if you deplete the other components that have been accumulated that prevent glutathione from forming and being utilized properly, such as mercury and mycotoxins and metals in general, you have a better chance at solving the health problem. So you might consider in your mind asking them, what's in your wall? That's a paraphrase on a common advertisement. So that's the points I wanted to make. There's a number of things that influence our efficient defense. I talked about the Th2s, the SNPs, just in summary, metals like mercury, mycotoxins, which are associated with TGF-beta, and the metabolic changes. So just like they did in Game of Thrones, they had these unknown white walkers. What are these things? What are the things that we don't know about yet that are going to influence our health? And my experience is we need to consider some things that are really difficult to diagnose commonly, and it's not the topic of this presentation, but parasites may play a role in this in a really subtle way. There's an interesting article that shows that in mice who'd been immunized with TB, when they skin tested them, their TB response diminished if they were loaded up with parasites. And they treated the parasites in these mice, their TB response came back. So it's really a fascinating observation that is food for thought for future presentations and for our understanding. It's a real dilemma, understanding all the factors that can influence patients' health. So I hope this has been helpful, and that's what I came to say today.